Good morning. Good morning, Alan.
Good morning, Andy.
This is our Sunday morning return to healing conversation. And today we're going to go back to an old friend, which has been around for a lifetime, which is high blood pressure in the elderly. A couple quick little things I'll say before I throw it to Alan. Number one, I recently saw a patient who's older, in his mid 80s, lives in independent living with his wife, falls constantly, has fatigue, some mental status changes. And he saw two wonderful doctors. He saw a nephrologist, who was a kidney doctor, and a cardiologist. The cardiologist, I read the note. It was quite interesting. We can talk about it in another talk, but put him on high dose statins because that's what you're supposed to do. He said that's just standard of care. And he also insisted he go on Eliquis for a few beats of atrial fibrillation. And what he wrote was interesting. He said, without Eliquis, you have a 10% risk of getting a stroke every year. And that
we know that's not accurate.
Right, and we'll talk about that in a future one. And that if you and there's no contraindications to Eliquis, it doesn't have any side effects. And then he writes in the thing. So I asked him, "Do you want a stroke or don't you want a stroke?" So that was kind of scare tactics they use. Then he saw the kidney doctor, and his creatinine went from like 1.3 to 1.5, probably because he doesn't drink anything. He's a little dehydrated. So decided to push his blood pressure lower. And put him on a medicine called Norvasc. He has a wound that's not healing in his leg. His legs blew up. The wound blew up. The doctor said, hang the course. You need this. The lower, the better. And this guy now is falling more. He's tired. He's dizzy every time he stands up. But to the nephrologist, this is a great success. And because he's on the Eliquis, when he falls, he could die. So this is what we're up against. So blood pressure is a big issue because there are new guidelines out. And the guidelines say to push people below 120 regardless of their age. And it's by the American College of Cardiology, American Heart Association. When I was a resident, Alan, a new study had just come out, which is called SHEP, systolic hypertension in the elderly. Before this, we just kept people's blood pressure as high as their age, basically, plus some number. So like 190.
100 plus your age. Yeah, that's your blood pressure.
So SHEP showed that, once the blood pressure consistently starts ranging above 160 in older people, and that's consistently, meaning every day, that your stroke risk increases. It doesn't increase at all at 160, according to SHEP, but as you go higher, there's a slight increase in the stroke risk, if it's that way every day. And that was, to me, a rational study. It was done well. It said, look, we can't just be keeping people at 190, 200 all the time. This seems to be a decent, reasonable number. And then, Alan, reason went out the window and we lost our collective minds.
Well, Andy, we lose our minds all the time in medicine, and it's about, treat. The lower, whatever it is, the better. And we know that's not the true. And Andy, the case that you described, I know you and I, this is not a rarity. It's every day for me. So, every time one of my patients has gone to a cardiologist, and those are mostly the ones that I'm not referring to on a regular basis, but sometimes mine, and because I have a cardiologist that works with me in the office, and we talk about our patients, So he actually comes to me and says, I want to push the blood pressure a little bit on this patient and why. And I said, all right, we could try it, but let's, see how dizzy they get and things like that. So those patients are every day. And these guys, to me, and we'll talk about, one of the recommendations in the new guidelines is like start two drugs at one time. Like I never start two drugs at one time. You start two drugs on one time for anything. You're not sure what's causing the side effect when the patient gets it. So I always think it's a mistake to start two things. But these guys go, and if they're not on aspirin, they start on an aspirin. If they're not, on an anticoagulant, they start on an anticoagulant. If they're not on a statin, they start it, and they start two blood pressure pills. And the patient went to the cardiologist in reasonably good condition because their relative told them to go there. Like, you don't see a cardiologist, you got to go see one. And they come back on 5 new medications, and they feel like crap. Like, I get that at least once a week.
Yes, all the time. And they feel like crap. Everything that was good, and this is what they tell me, is that God, thank God I'm on these medicines because it saved my life. Again, I was about to get a stroke. I was about to get heart attack, and these guys came in like superheroes and saved my life. I said, but you feel terrible. And it's like, well, I'd feel worse without the
Huh?
medicines. That's what they told me. It's this deception. And by the way, we're not telling anyone to get off their medicines. That's not
No.
our job here. But we do believe people should have some knowledge that a lot of what these specialists are saying, to use a very sophisticated word, is bullshit. And I don't know where it comes from because you and I, Alan, look at the literature, but I could tell you, if you go on AI, it's fed by some of this cardiology nonsense. And
Absolutely.
and I question AI. I say, "Are you sure? What about this study, this study, this study?" And AI would say, "Well, you're absolutely right." And I say, well, "Why didn't you put those in the original question?" They say, "Well, this is standard of care now." And standard of care is basically to do things against your self-interest, and to feed yourself with medicines. And it's really, I was there. If you go on YouTube now, this is interesting. There are a bunch of videos by doctors, and just as a caveat, as you know, I was scolded by the Board of Medicine in Maryland because the cardiologist felt I was disseminating misinformation, i.e., giving people information that is true and that goes against their dogma, such as the 10% of people will get a stroke every year. And God knows I have 300 people not on Eliquis with atrial fibrillation for years and years and years. I've never seen a stroke. So, but anyway, um, I got in trouble also for what I said about blood pressure, which is that in older people, you sometimes need it higher. And because they need better perfusion, they need better blood flow. They have blockages everywhere. This is what you need. The body pushes it up. And there are a lot of videos on YouTube by doctors that are essentially saying the same thing. They're
Yeah.
angry doctors saying, why are these guidelines telling people to do things against their self interest when studies and experience don't support any of
Yeah.
that?
Well, our experience is not important because we're not the cardiologists, but a couple of points I just want to make about the data. And, we've talked about data and misinformation from the studies. We know that most studies are eventually proven wrong anyway, with time. But there's a few things that always stick out when I, teach my residents who were very young learners, like how to look at a study. Like, okay, like maybe the result is the result they got because that's the result they wanted to get. And we look at a few things, like when you take stroke and you say 10% of people had a stroke, we know the real doctors who look at the data, like what was a real stroke and, what was a change in someone's CAT scan or MRI, So I recently went through this with a relative of mine who was a little dizzy in walking. The guy is 86 years old. He got a little dizzy walking. And, so what did they do? The first thing is an MRI of a brain. He must have had a stroke. And there was like two dots. Like I couldn't even see them, like when they were showed to me. And I'm like, now, he needs anticoagulation because it had to be AFib because they were two dots. So it couldn't have been one thing. It had to be two events. So that's one thing. Like we don't interpret the data. Second, as Andy knows much more than me as the geriatrician here, very few of the stuff is looked at in the elderly. Okay. And the one that I just see the most, and I rarely ever see it discussed, is defining like what people actually die from. So when they talk about mortality rates, and you talk about mortality rates in an elderly person with hypertension, for example, if the elderly person with hypertension is pushed by the cardiologist to a blood pressure that's not sustainable, they fall, they break their hip, and they die from complications associated with that, it is not considered an event related to something they would report. That cause of death is hip fracture. Okay. So
Right.
it doesn't go into the cardiovascular event. And the other thing is they overestimate cardiovascular events because we know that everyone that goes to the ER that's elderly gets a troponin level, and we've talked about troponins. So and troponin, folks, is the cardiac enzyme that's released if you have some cardiac damage. It doesn't equal MI, but now they've made it equal MI. So if your troponin is 1 point above what it is, you had what's called a non-STEMI, non-ST elevation MI, and I'd say like 80% of my elderly patients walk out of the hospital now with a non-STEMI, and they were there with septicemia or a fracture, whatever it may be. So we're
Or
just
or a pain in their toe,
so
Alan. It
yeah.
could be
So we're just not interpreting things the correct way. So it's so wrong in how these guys look at it, and they don't dig into the data that they're looking because they feel everything should be lower. Your blood pressure should be lower, your cholesterol should be lower, your sugar should be lower, everything should be lower, and it doesn't matter if we make you fall, pass out, and get hurt.
and that's right because the biggest study. So the guidelines from American Cardiology and American Heart Association, and we've talked about these are tainted organizations, very very tainted organizations. But there was actually an article in the JAMA Journal of Ethics, which I always think is funny saying
Mm.
the AMA and ethics in the same sentence. But
Be careful, Andy. They're listening.
they have a journal. They already got me in trouble so many. Wait till they see my thesis. But anyway, the JAMA Journal of Ethics said the American College of Cardiology famously includes studies with no older people in it and makes its recommendations to older people. That's coming from JAMA. And the American Heart Association is exactly the same. They are a pharmaceutical driven company. They're run by pharmaceutical by doctors from Harvard who do all the research for drug companies and are paid by pharmaceutical companies. Other than like,
And are not practicing real world medicine like we
no,
do.
they don't. They have no experience. So it's just basically they're number pushers, and they always say, "Oh yeah, take care of lifestyle," but here's what you got to do. So they too do not look at older people in their studies. There are a lot of studies on blood pressure on older people. And when I went to AI and just asked them a simple question, because everyone looks at this one study called Sprint. And Sprint is a tiny little study that apparently
It's
shows
godly, though.
no, it is taken on a religious aura, like much of the cardiology literature, and it's dogma, and you can't question it. I think there were 1,500 people in this study, and it was all people with high risk heart disease. And it should be known that you have to look at who they're studying because it's not always applicable to everyone. And they added a medicine that may have helped their high risk heart disease and had nothing to do with blood pressure at all. And you can see in the literature tons of doctors screaming about Sprint also what a garbage study it is. And yet it has become dogma. But a few things about Sprint, the reduction in death, which they count as like 30%, is 1 out of 1,000. And even among all these things we're talking about that probably have nothing to do with lowering blood pressure below 120. Number two, they ignore what they call the soft side effects, which Alan and I see every day in people with low blood pressure, which is dizziness, tiredness, loss of mental status, falls. Am I missing something, Alan? There are a lot of them. They feel like crap.
It's everything.
It's everything. They're just doing terribly. And also, what they never talk about, and this is interesting because of the story I told about the kidney doctor, is that lots of people who had the lower blood pressure developed kidney disease, and some were hospitalized. And in fact, in the people who on the low blood pressure regimen, the hospitalization rate was much higher, and then the people not. But they kind of poo-pooed that. So I asked AI. I said, other than Sprint, if you remove that from the what are we going to call it, the gospel of blood pressure, all sorts of studies show pushing blood pressure too low is bad. There's a huge VA study that shows if you push blood pressure in people with chronic renal disease below 120, the death rate goes up and the kidney disease gets worse. You had an Accord study which showed the same thing. Which people with not high risk heart disease, you push it below 120, their death rate goes up, their kidney disease gets worse. Ironic that kidney doctors are pushing blood pressure low given this reality. And recently in JAMA, again, Journal of the American Medical Association, a 5-year longitudinal study came out that showed in elders who pushed their blood pressure below 120, the fall risk increased dramatically and the death rate increased. All this stuff doesn't make it into the ACC guidelines. The ACC guidelines basically relies on this one study, Sprint, and then a bunch of junk observational data, and we've talked about what that means, and creates this new gospel of what you have to do. The reality is, especially in older people, but in other people, low blood pressure can be incredibly dangerous, and you have to moderate. I mean, that old study of SHEP of 160 is kind of where we should aim for. And the American Family Physicians Association uses 150 as a guideline. The American College of Cardiology says 120, and Medicare is required to base its guidelines on specialty societies, not on.
Right, because we're two schmucks. We
We're
know
two
nothing.
schmucks,
We're
and
just
our
primary care docs. You're a primary care internist. I'm a family doc. We don't know
yeah,
shit,
I,
and that's what it's all based on. And then we could shift a little bit. So I agree with you about the studies and all that. But now the new thing is, the risk stratifying of patients based on quote those studies in the prevent calculator. And
oh
you know
God,
I,
God help me.
a resident cannot present a case to me without talking about the prevent calculator. So they actually walk around with the calculator, and every patient they see, essentially that's an adult, they come to me with their prevent score. And patients on psych unit, we admit patients to the psych unit in the hospital, and they're giving me the score, and like the patient should be started on aspirin, a statin, and a blood pressure medicine, being admitted to psych for psychosis. There's just no rational thinking anymore in medicine.
There are calculators for atrial fibrillation, for coronary heart
There's a
disease,
calculator for everything.
and they're all based on drug company
How much
studies that are
gas you have in your bowel and the number of
exactly.
farts you should have.
I
That's
would say pre constipation is another one. The yes, the calculators are programmed with drug company studies that are
yeah.
highly manicured, and they are now made into. So it sounds like they'll say, well, now you have a 12.7 5-year risk of breaking a hip. I say, based on what, Mom? You've fallen 12 times in the last year. You haven't broken anything. You do yoga. You take care of yourself. You eat well. They don't care about any of that stuff. And that brings up also with blood pressure another caveat, which is another story. When I started at Albert Einstein Medical School, I think sometime in the Stone Age, and I decided to set up in the South Bronx a screening program for blood pressure, and we happen to have a blood pressure guru in our medical school name. I think his name was Harriman. Does that ring a bell? I think, and I wish I remembered his name, but he was the guy. And so in our first meeting, I recruited like 60 kids because
Well, we don't want to say real names anyway because it just gets us in more trouble.
so it's probably a fake name. My memory prevents me from remembering. So I had 60 medical students because all medical students want to do something they can put on their resume and to go help people. And he gives us a talk and he says, "Let me tell you two things. First of all, what you're doing is utter nonsense. You're going to screen these people for blood pressure and then not be able to do a damn thing about it." He said, "Number two, the idea that salt causes high blood pressure is such a fantasy that it makes me actually faint when I talk about it." He said there's about 10% of people who are salt sensitive, and he said you know who you are because when you have salt, you swell up. You
That's
bloat
right.
up.
You got fat legs,
You got fat legs.
and
You
they're
got
much more in
10% of
women.
people. 10% of people, he said, who need salt. If they don't have salt, they're going to faint, and their blood pressure, ironically, will go higher. And then you have 80% of people, it doesn't matter. He said the world is focused on salt because it doesn't want to focus on what really matters, which is that we're eating shit diets. And he said in the South Bronx, people can't afford good food. And if you want to really help these people, don't go and screen blood pressure, but lobby Congress so people in this area can eat well because processed foods, junk foods, high sugar diets, that's what causes high blood pressure. That's what causes death. That's what causes heart disease. And fixing it with medicines is useless because you've created such an inflammatory situation.
Look,
He's the first guy I ever heard say this.
well,
And
that's a
since then,
long.
I've read millions of books and articles about this, but the medical community is so stuck on salt that it will not talk about anything else. It's insane.
And they say they talk about prevention. They talk about prevention, but that's not what they're teaching people to do. Andy's 100% right. We need to be out in the communities talking about lifestyle medicine. We need to be talking about what's in the supermarket, what they're doing with that, and how much they're exercising. Because we know that food is the number one killer in this country, but the food lobby is, what do we say, second in line to the healthcare lobby, Andy, and
Yeah,
in
yeah.
what's
They
out
work
there.
tandem
So,
in
so we're
tandem.
not going to win that one either. Can you put on TV for 5 minutes without a fast food commercial? Probably not. Not that I watch much TV, but I do watch a
I
little
do, and it's
sports.
true.
There's a little sports on there,
It's
but
not. It's
you
not even
can't do
fast
it.
food. It's sugar, sugar, sugar cereals, sugar
Sugar and
snacks,
sports
sugar,
food. It's
sugar.
it's the two enemies. Sugar processed, we hate to say it, but we know who's talking about that. We're not allowed to say he's right on this one because we'll get in trouble. But good old RFK Jr. He's
He's
got
been
us
talking
some
about
good
it.
points. That's one of them.
And he wants to keep it out of the schools, and they voted him down. So because God forbid people should have a choice to eat sugar. The thing is that people get insurance that will pay for drugs and tests, not for food,
Yeah,
not for lifestyle, not for exercise. And if in an area like where you work, Alan, people are working two jobs, they can't exercise. They go to a store, they can only have so much money, they only have so much time. They don't have money to be buying this stuff that they should be eating. It's quicker to get junk. And no one cares about that. They,
yeah,
they, they will give those people drugs, and they will give those people tests, and they will put them in pay for their hospitalization
that's right.
after everything fails, but they will not prevent. And then they start talking again about salt. And it drives me crazy when the cardiologists say, just go on a low salt diet. And I say to my patient, you have low sodium and you fall down all the time. I said, no, I've told you to eat more salt. Well, the cardiologist said I should go on a low salt diet. That's because they are robots. They are robots who just repeat this line. To them, that is nutrition. They've now given
Yeah,
you all the nutrition they know, which is that everyone should go on a low salt diet, and they know nothing about you as a human being because they don't care because they have a calculator.
yeah. The calculator is more important. Look, we've both been practicing a long time. I've been practicing for 40 years now. I feel very old, so it's been going on a long time. But never in my career have I started someone first line on a diuretic for the treatment of hypertension that didn't come in swollen. Like to me, that is the only indication to do it. Either they're swollen or they're in heart failure. Yes, if they're in heart failure and they're swollen, you could treat their hypertension that way. But everybody else, to me, it was always the last line drug. And now, because salt is so important, everybody should be on a diuretic now. Why even lower your salt? Just take a diuretic.
Yeah, there are drugs for that too. And
There's a drug for everything.
and I got to tell you just one more thing about this because
There's
we're
drugs for
traveling
hair
on a
growth
lot.
now, Andy. You might want to look into it.
Well, it's too late for me.
You could go on a biologic to grow
Oh,
hair.
I bet there is a biologic
No,
for me.
there is. There is.
I might have amyloid in my scalp, which is something else we can talk about next time, which is the amyloid craze. But they create problems once they have a drug to solve them. But yeah, one other thing, and I'll ask you what you think about this. Again, the cardiologists are of a unit. I don't know if they're all the same. If they're, in Star Wars, they created these clones, and I just wonder if, like, one person gets accepted cardiology fellowship and they just clone them
Yeah.
because they all speak the same language, but maybe your guy doesn't. But I
Well, they
don't
are
know.
important people, so why make new ones when you could just
Yeah,
clone them? So
exactly, and they do make a lot of money for
that's
the
right.
system, a lot of money.
Well,
So
the only one that makes more than them are the interventional cardiologists.
oh
So
yeah, but they're still counted as the cardiologists. They're I think the number two highest paid, not doctors in the world, people in the world. People don't question that, which they should. Like, how are they paid so much? Well, they convinced me to beat you people against their. Anyway, we'll go into
and,
that later.
and the fact that the interventional cardiologist is the one that's making the decision if they should do a procedure on
Right,
someone that they stand to make like $25,000 on
self
is
referral.
is just utterly absurd that it's allowed. Like we could so cut them down by saying, you know what, you need two doctors before a non-emergent cardiac cath. You need a good primary care preventive cardiologist and their primary care physician. Those two people should get together and say, okay, now the patient needs the cath. And
And
folks, this is different if you're having a heart attack and you're going into the
yes,
ER. You
that's
need one.
different.
So we don't want to say we're killing anyone, but we all
Emergency room cardiology is actually very effective.
we all know the treatment for asymptomatic cardiovascular disease is prevention, lifestyle
Lifestyle.
modification.
Lifestyle. We know that it's not drugs. We know that. That's been shown over and over again. It's not in the calculator. By the way, everyone in the blue zones where they lived forever would fail the calculator.
Oh yeah.
They would all be told.
None of them are taking antihypertensives
No,
in the
they're
blue
all be
zones.
told they're at high risk. Better go on those blood thinners, or you have a 10% risk of a stroke.
And they're having an extra glass of wine a day too, so they now are failures to die immediately from the complications of alcohol. From drinking like 3 little glasses of wine a day.
Exactly.
You're dead. That's it. Cancer and cardiac calculation.
The last thing I want to bring up is this, and I run into this all the time. What is the real blood pressure, Alan? I mean, people come into the office, it's one thing. I could measure it 4 times in the office. I'm going to get 4 different blood pressures. I tend to get lower blood pressures than most other doctors because I don't check it till we've been talking for a while and we're laughing and giggling and having a nice time, and then I'll check the blood pressure. Yes. So you get yanked into an office, or better yet, you go to a hospital because you just fell down. Your blood pressure is 210. They did a big study, Alan, and looked at people, and everyone ignores these good studies. They looked at people who show up to the hospital with high blood pressure, over 180, and they brought them into 2 groups. One we treat and one we didn't treat. And the treated group had higher stroke risk and higher kidney failure risk than the non-treated group. High blood pressure is going to go up when you're stressed, and we stress people.
Even in their own guidelines for the treatment of the emergence of treatment of hypertension, it's in their guidelines like that. We shouldn't be treating numbers and taking into account the situation that you're in. So someone breaks their hip, their blood pressure is going to be high. Don't give them an antihypertensive. Give them some pain medicine for a day. Fix their broken hip, and it will come down miraculously. It's not the blood pressure; it's their pain. By
the way, no rush in bringing it down either. Wait till they see their primary care doctor.
Absolutely.
And there's no rush. You don't have to. The hospital feels like, okay, we got to check all these boxes and fix all these things, call all these specialists in, but you don't have to. And I got to tell you, Alan, the sound of the cuff on an arm, I think, raises people's blood pressure 20 points.
So in my office, I do have medical assistants that room the patient. They take their vital signs and their blood pressure as soon as they come in, and we know it's wrong. When I walk into the room and the patient says my blood pressure's high, I said, don't worry, when we're done, I'm going to take it again. It will be a lot lower. And I go into that. We're really supposed to wait, but I need the medical assistant to room and get some vital signs into the chart and things like that. So we have that discussion. And I would say 90% of the time before the patient leaves the office, it's either normal or much lower. Okay. And when it's not, according to these guidelines, you just start medication on that, which
that's the problem.
Utterly absurd. They don't stress multiple readings. They don't stress that if it's asymptomatic, give it more time. They don't really stress the number of complications that someone may have. Okay. And I do push people to to get a blood pressure machine, because invariably, and I always have them bring them in to make sure it's accurate. So I have them bring in the blood pressure machine. You check the blood pressure in your machine. I check it me, and I say, look, it's accurate. Okay, so we're going to see what your numbers are. And again, 90% of the time, it's at least 50% lower than what's in the office. We know blood pressure readings in the office. That's why they made up another diagnosis, white coat hypertension. Look,
exactly.
It's probably one of the earliest diagnoses they made up, right, Andy? White coat hypertension.
Doctors causing the problem.
It's a good one,
though. We always do. But the studies, the big studies on blood pressure, have people lie down for a half hour and they check 5 blood pressures. But then their recommendations are, if you get 1 high blood pressure, you treat it. And it's kind of ironic that their studies do it the way you should, that none of us have time to do. But the idea of them checking it on their own at home and just looking at one day it was 170, one day it was 120. Okay, I get it. The 120 is probably your accurate. The 170, you're not going to drive your blood pressure lower usually, but you can drive it higher just by looking at your taxes. And when you're older, it's very labile. When you're 30 years old, the range of blood pressures is very narrow. When you're 80 years old, it could go from 210 to 120 instantly based on how you're doing. And so you have to be reasonable about this and look at kind of what it usually is. And I always tell my patients, it takes about 10 years for very high blood pressure, very high. And that's consistent blood pressure over 160 to cause a problem. Look, FDR walked around, that's Franklin Delano Roosevelt, with a blood pressure of 250, smoking 2 packs a day, and his doctor said that's fine. It took him about 20 years before he got his bleed in his brain. We get people bleeds quickly by putting them on Eliquis, but that's another story. But it took him that long. However, I'd say a low blood pressure can kill you instantly, that day, that minute. So we will err on high. I always tell my patients that.
Yeah.
I'd rather err on the high side before we start figure out what's going on. Because if you drop low, you're going to fall. You get a stroke. You can knock out your kidneys. Lots of things can happen when you drop your blood pressure because you don't have blood flow to your organs. Or your brain. So you can kill yourself.
And
that blood pressure takes forever to cause a problem.
Right.
People
And
say, well, I had blood pressure of 180 yesterday. I'm going to get a stroke. I said, it doesn't work that way.
And I tell people, we got plenty of time to get your blood pressure controlled. You're not having a stroke now. So if you're not having a stroke now, you're not going to have a stroke. So let's start really low. You know, my motto has always been in the treatment of hypertension, start very low, one drug, go really slow, get used to are there side effects or not? And if we need to tweak it a little bit, we will. But these new guidelines are essentially pushing the young people, because when the young people read this, they say, someone comes in with greater than 130 over 80, you should be starting 2 drugs, 2. It's insane. Yeah. 130 over 80.
But it's not insane for the pharmaceutical industry. It's very good for them, which is what a lot of this is for. And the cardiologists who make these guidelines are working in tandem with that group of people. And it's really makes our lives harder, because people, like in the story I started with, the daughter said to me, because I said she shouldn't be on these statins at all, let alone this dose. Eliquis, a freaking dangerous medicine. His chance of getting a stroke on Eliquis is higher than not on Eliquis. And I could show you all the studies to show that. We wrote one, Alan. And low blood pressure is going to cause his kidneys to get worse. And she said, well, now you're talking against the experts. So this is what we're up against, because we're schmucks. We're not the experts.
To me, you know, I'm going to get myself in trouble now. One of the biggest dangers in the world is actually to see a cardiologist. I'm going to give a story.
Yes, it is.
That doesn't work with me. So 3 weeks ago, I have a couple come into the office for their routine annual checkup. All right. Somebody's blood pressure was a little high, but the woman in the couple was having some symptoms, some dyspnea on exertion, and I was actually a little concerned that it could be an anginal equivalent, okay? So what that means is you're short of breath, and the shortness of breath is actually being caused by cardiac disease, not just, let's say, a lung problem. So we went through this thing, and they said, well, you know, our friend said we need to see a cardiologist. You know, you're gonna. I can't object to that. God forbid I object, you know, and I do object and say, well, this is what they're going to end up doing. So both of the couples go together to the cardiologist.
It's a date.
It's a date. And they're now back for their follow-up from what I discussed a few weeks before. And I looked at this couple, and they looked at me and said, you don't agree, right? So the woman that had the shortness of breath on exertion, they said that she was fine. There was nothing wrong with him. But they both did stress tests, and her stress test was normal. And his stress test, who had no symptoms, just decided to go with his wife, was abnormal. And he had an angioplasty and stent before even got back to me. And they both saw my face and said, what, you don't approve? I said, I'm sorry, I don't. I said, if your wife would have had angioplasty and stent because she had an abnormal stress, I would actually maybe agree with that, because she was having symptoms and you don't. So I thought it was okay that she went, but you went and you got something totally needless, because the treatment of your condition should have been lifestyle modification. And I see this every day. Something is wrong with our country. Something is wrong with our healthcare system. And one of the other risk factors of being one of my patients is actually being more educated or more money, because you're going to end up seeing cardiologists more and getting these things more than someone that just listens to me, the schmuck family doctor that just says, lower your blood pressure slowly. Okay, let's treat one condition at a time. Let's get you where you need to be, and you'll be healthy. Go to the cardiologist, get a cath. And we know that's the case. And if you actually read their own guidelines, it says it, but they don't follow it. It's just mind-boggling.
They follow the guidelines that support them.
We all know that getting a routine EKG is not indicated and dangerous. Because why? Because you can end up with a cardiac cath from having an EKG.
Yeah,
and that's the example.
And we could talk about that in a future thing, that these stents actually make people put people in higher risk, that treating people with Eliquis when they have a little AFib can put people at higher risk, that going on statins could put people at higher risk, putting people on amyloid drugs can put people at higher risk. But the cardiologists put you on all that stuff all at once the first time you meet them and do a lot of tests that are useless. But yeah, and you talk about affluent people. One of the reasons they say, well, look, we're living pretty long. I say, yeah, you guys go to the gym, you eat organic food, you don't eat a lot of sugar. I said, it has nothing to do. You're lucky you're alive this long because seeing this cardiologist is actually taking away your longevity. And also these affluent people are on AI, on Google,
Yeah.
and those are all giving you programs that are pushed by the drug companies because the bots will put those programs in there a billion times. So that's what shows up. And I asked AI if that's the case, and AI said yes. It was interesting. If you ask AI the right question, they will be honest about it. We'll talk next time about how, because I was looking into drugs for amyloid, and I asked the AI questions. And you know what the AI said to me? They said, I think that's a good question, but when I went to pursue it, a bot blocked me from asking that question. So it is very well set up. So you think you're an intelligent person, you check the AI, you do your own research, and you end up harming yourself. But you have this
Yeah.
self delusion that it's helping you. And the thing is, you are living a good lifestyle. So that is unfortunately, I'm glad people are living a good lifestyle. I told one of my relatives who was upset that her other relatives are on all this stuff. She went to see her friend, and this friend said, well, thank God I'm on these medicines because this is
Thank
why I'm
God.
alive and healthy. And I'm not going to say who it was. She said, I don't think so. But I said, Mom, this is their religion. I said, this is their faith. They believe in it. Leave them alone. Well, you're not gonna change their minds. The good news is they're eating well, they're exercising, they're active because they got money, and so
Look,
they could do this. But the poor people in this country aren't so lucky,
yeah, you know what,
unfortunately.
Andy? Like, we just when I don't see an out. At times I'm, hopeful about our healthcare system. There's just no
When?
money. There's just no money in health. Unfortunately, there is no money in health. There's no money in prevention. Nobody makes any money except, I don't know, the farmers, I guess, and they don't make any money, so we
No.
barely help them. There's just no money in prevention. There's no money in trying to keep people healthy. There's only money in testing and treatments, and it's
Deception.
unfortunate. And the people that are controlling the system, including the AMA and the organizations and the American College of Cardiology and Diabetes, are pushing more and more drugs and treatment. The pharmaceutical companies are pushing more and more drugs and treatment. And the pharmaceutical company. So I actually had a meeting this week. It was actually a really good meeting with the American Academy of Family Physicians. They actually reached out to me and said they heard about some of the good things I'm doing in primary care in an underserved community. So they asked what we were doing, and I had like 15 minutes to prevent what I was doing. And what I was doing was prevention in primary care. And I was giving my doctors more time to help keep people healthy. And we now have data from 3 years that we're going to get published soon that shows that good aggressive prevention in an urban inner city setting will cut down on ER visits, hospitalizations, and total cost. I have that data, like
That was
saving
amazing.
$7,000 per patient. So we're going to get our first one pager in a month or so in the Annals of Family Medicine, but we're actually preparing the big journal for either hopefully JAMA or the New England Journal because we actually have the data now that shows it. And they said, well, do you see your thing being replicated somewhere else? And I said, no. And they go, why? I said, because it's going to cut down on hospitalizations, procedures, and ER visits. And nobody wants that in the medical industrial complex. They think that sucks. Like, we need our hospitals filled, we need our surgeons active. The more the better.
And that is the sad reality, Alan. This is what you're doing has been done on a global scale. There's a Dartmouth Atlas too
Oh, yeah.
that looks at this,
Oh, I
and
love the
no,
Dartmouth Atlas.
it's
I love
amazing.
the
It's
Dartmouth
amazing,
Atlas.
and it does show that despite income, the more specialists you see, the worse you're going to
So
do.
let's not leave these people in a lurch. The Dartmouth Atlas, you could go on. Anyone could go on the Dartmouth Atlas. And if you look at the cost of medicine, let's say in New York City or Chicago or Los Angeles or any of the big cities that have academic health centers, the cost of care is like double. The number of treatments is like double. The number of procedures is like double. The number of time people spend in the hospital is double. And the cost per care is double, with lower patient satisfaction and higher mortality rates. It's proven. Just go to
It's
the Dartmouth
proven.
Atlas. It proves it all that. And that's
It
just
does.
CMS data. It's
And it's
not
CMS
fake.
data. And
It's
yet
it's real
people
data. And
are
they ignore
so,
it.
people are in such a cloud that they just feel like, well,
Cardiologist probably doesn't even know what the Dartmouth Atlas
oh,
is.
they don't. They probably think it's an atlas of where Dartmouth is on the map. I think that's about it. Well, Alan, we overstayed our welcome today, but this was a good conversation, and we will
There
get
could
to
be a few
amyloid and
medical
other
board
things.
phone calls this week.
We will, but that's nothing new. I think I might just invite them over for a weekly visit so they could give me more, more advice. And by the way, they told me to stay in my lane. That was their, that was their conclusion of their reprimand, which means I shouldn't be talking about cardiology. I should leave that to the cardiologists, who know nothing about cardiology, ironically. But of course, have just gotten out of my lane today, and I've stayed out of my lane because I have to,
So you're
unfortunately, to
actually in
protect
the
my patients.
appropriate lane. You're in the right lane.
I'm in the
Right
right lane.
lane is slow medicine. You remember
Slow.
slow medicine?
Yes.
That is one of the answers to our healthcare problem. Slow medicine. What was his name?
Slow, man.
Rob McCullough. You remember we met the
Oh,
guy who
yeah.
wrote the book, Rob McCullough.
I love that book.
It's a
I love that
great
book,
book.
Slow
You
Medicine.
want to know how to be treated? Read the book Slow Medicine.
And that's the way we practice, and that's the way we should. And that's unfortunately not being done anymore. When you go to the cardiologist and walk out and 8 drugs and a stent, it's not going to happen. Anyway, Alan, have a great Sunday.
You too, Andy. You too, everyone. Don't forget, Return to Healing. It's the best book ever,
Best
folks.
book ever.